My name is Mirna Vergles. I am a pulmonologist working at University Hospital Dubrava in Zagreb, Croatia. In this short video, I would like to briefly present the results of our study that explored whether it's feasible to taper the dose of anti-eosinophilic biologics in patients with severe asthma who are in sustained clinical remission. Today we have evidence that biologics are highly effective in severe asthma, and there is a broad consensus on when to start them. However, what happens after treatment initiation is much less clear. We have very limited data on key clinical decisions, such as how long to continue treatment, when to switch, or whether treatment can be reduced. GINA acknowledges that some patients who achieved sustained asthma control might be candidates for stepping down the therapy, but it does not offer guidance on how to do so. In fact, only one clinical trial so far, the Optimal study, has addressed the issue. The aim of our study was to assess the feasibility of 50% dose reduction of anti-IL-5 biologics, benralizumab and mepolizumab, in patients with sustained clinical remission by progressively prolonging the intervals between doses. As you can see, 31 patients who had been in stable clinical remission for more than a year were enrolled. In all patients, we firstly extended the dosing intervals by 25%. If full remission was preserved, the interval was further extended to achieve a 50% dose reduction. At the end of the study, 50% of the patients maintained full 4-component clinical remission. However, 42% of them experienced partial loss of asthma control, and 3 patients had acute exacerbation. Blood eosinophil count rose slightly, but remained below 300 cells per microliter. FeNO levels stayed stable. There were no significant differences between the two biologics. These findings suggest that biologic dose reduction may be feasible in carefully selected patients, but a uniform 50% interval extension carries a relevant risk of compromising full remission. Further studies are needed to identify optimal candidates and refine tapering strategies, possibly using type 2 biomarkers or bronchial hyperresponsiveness to guide safer, personalized decisions. Thank you.